name is Dr. Asl Abdulameer Majeed. I'm currently an intern under Dubai Health. So I'm very excited to present my case today. It's a case of unexpected high plasma vitamin B12 levels. So this case focuses on the unexpected finding of elevated plasma vitamin B12 in a patient with no history of supplementation, and as well as its diagnostic challenges. So elevated vitamin B12 level often prompt concerns about serious underlying conditions, making this an intriguing case for clinical discussion. So high serum vitamin B12 levels are commonly associated with oversupplementation. However, when levels are elevated without supplementation, this raises red flags for certain conditions, such as solid tumors, hematological malignancies, and renal dysfunction. So vitamin B12 or cobalamin, as we all know, plays a crucial role in neurological health as well as hematological health. And while low levels are very commonly investigated, extremely high levels demand careful investigations to rule out potential underlying pathologies. So this case emphasizes the need for a structured diagnostic approach to hypercobalaminemia. So I'll just walk through a bit of the case details. So our patient was a 30-year-old female. She was married with 2 children, and she was referred to us due to elevated serum vitamin B12 levels that are detected during an evaluation for joint pain. She reported no history of vitamin B12 supplementation, and initially her B12 levels were 2,000 picograms, which later rose to 7,000 over 3 months. She experienced non-specific symptoms of joint pain and body aches, predominantly in her hands, but denied any systemic symptoms like fever, rash, weight loss, or gastrointestinal complaints. The clinical examination was unremarkable. There was no lymphadenopathy, no thyroid abnormalities, there was no hepatosplenomegaly, or joint abnormalities were noted. We did initial investigations. There were comprehensive tests that were done, including CBC, liver and renal function, thyroid function, peripheral smear, and even the imaging studies were all normal. Given her persistently elevated B12 levels, she underwent further evaluation with homocysteine and MMA, methylmalonic acid, and active holotranscobalamin measurements. So the active holotranscobalamin was elevated, but the homocysteine and methylmalonic acid were normal. So these findings ruled out functional B12 deficiency. So due to concerns about occult malignancies or systemic condition, the patient was referred to a hematologist and an oncologist so that a thorough workup to be done to exclude any of the conditions. So we did a bone marrow examination, we did a flow cytometry, and we did CT imaging of the neck, the chest, and the abdomen. And all the findings were normal. And over 6 months, the patient remained clinically stable with no evidence of any underlying disease. So at this point, there was the possibility of macro vitamin B12. So this phenomenon occurs when cobalamin is bound to proteins like immunoglobulins, creating large molecular complexes that may elevate the serum B12 levels in the absence of disease. So because it will be a large molecule, it will tend to raise the serum B12 levels. And so this case really highlights the complexity of interpreting elevated serum B12 levels. So there are certain mechanisms of elevated B12. There could be liver dysfunction, reduced clearance, increased production of B12 binding proteins. There also could be the release of stored B12 from damaged cells, as seen in malignancies. And there's also the presence of macro vitamin B12 complexes. So there is a lot of challenges when it comes to diagnosis. High B12 levels are not always indicative of functional sufficiency. Relying solely on total B12 measurements can lead to misinterpretation. And we'll also talk about the role of macro B12. This is a lesser known cause of elevated B12 levels, and it often presents an inert form of B12 that does not contribute to cellular functions. So the current testing methods like polyethylene glycol precipitation help distinguish between true and macro B12, but they're not widely standardized. And this controversy surrounding macro B12 emphasizes the need for further research to guide clinical management. So I'll just go deeper into the discussion. So we have the complexity of vitamin B12 that we already talked about, but it's really important to understand hypercobalaminemia, which remains a clinical challenge, and it could occur from multiple physiological or pathological processes, and it's bound to two key proteins, haptocorrin and transcobalamin. And of the total circulating B12, approximately 80% is bound to haptocorrin, which is a protein with a relatively long life and limited cellular uptake. And in contrast, the transcobalamin bound form, referred as holotranscobalamin, is the biologically active form of B12. So the elevations in serum B12 might arise from, like we said, increased release, decreased clearance due to renal failure or liver dysfunction, certain disorders such as myeloproliferative neoplasms, and certain cancers that can elevate haptocorrin or transcobalamin levels. But in our patient, all these mechanisms were ruled out through comprehensive testing, including liver and renal function tests, imaging studies, as well as a bone marrow evaluation. So what is the exact function of macrovitamin B12? So, like we said, these are biologically inactive, but they can raise B12 readings in the serum. So it's not a typical finding in malignancy-related hypercobalaminnemia. So it's something we rule out. It's something that we don't get scared of when we think about macrovitamin B12. There will be absence of systemic signs, absence of any signs of organ dysfunction. There will be no evidence of malignancy and extensive workup. And that's why we need to really do this polyethylene glycol precipitation, just so that we can separate the macro B12 from actual active forms. But this is really not universally accepted yet. So what are the other differential diagnoses? So we need to really assess the vitamin B12 forms. We need to measure the methylmalonic acid, the homocysteine, the holotranscobalamin, and we need to exclude as well malignancy and organ dysfunction. And there's a lot of controversy surrounding this vitamin B12. And it's really important to measure the total B12 in cases of macro or other binding proteins. So there are, of course, research gaps. We need to really define the prevalence and mechanisms of macro B12 in device populations. We need to develop standardized diagnostic protocols for hypercobalanemia. And we need to clarify the relationship between elevated B12 levels as well as long-term impacts. And the conclusion of my case is that it really underscores the importance of a comprehensive approach to evaluating elevated B12 levels. And it should always be considered the macrovitamin B12 when all the malignancy systemic diseases have been ruled out. So ultimately, this case highlights the diagnostic complexities associated with elevated serum B12 and the importance of clinical judgment in interpreting lab results. So thank you so much for your attention, and I'll be happy to listen to any questions you might have.